The following podcast is part of a certified educational activity titled The Expanding Advanced Ovarian Cancer Treatment Palette, Candid Conversations on Bringing Parp Inhibitors into Clinical Practice, featuring Drs. Deborah Armstrong, David O'Malley, and Shannon Weston. Access the entire activity and complete the post-test at peerview.com/BDQ860. Downloadable slides and practice aids are also available.
Hello, and welcome to the Expanding Advanced Ovarian Cancer Treatment Palette, Candid Conversations on Bringing Parp Inhibitors into Clinical Practice. I'm Dr. Deborah Armstrong from the Johns Hopkins Kimmel Cancer Center in Baltimore, Maryland, and I'm joined today by two of my colleagues, Dr. David O'Malley from The Ohio State University College of Medicine in Columbus, Ohio, and Dr. Shannon Weston from the University of Texas MD Anderson Cancer Center in Houston, Texas. So the agenda today, we're going to start out by outlining the rationale for PARP inhibitor therapy and leveraging genetic testing to maximize clinical benefits. We'll then move on to integrating the latest evidence on PARP inhibitors to personalize ovarian cancer management in the first-line setting with Dr. O'Malley. And then Dr. Weston will go through updates in ovarian cancer therapeutic opportunities in the recurrent setting. And then we'll all three discuss what's next for PARP inhibitors in ovarian cancer, including reviews of some of the most recent data from ASCO. So many of you have seen slides such as this or similar slides that outline how PARP inhibitors work and the concept of synthetic lethality. What you can see up at the top is that in the presence of a single strand break, based on DNA damage that occurs all the time, that PARP inhibitors normally will repair that single strand break. But that PARP will repair that single strand break. But PARP inhibitors actually don't allow PARP to repair that single strand break. And what you can see on the left is that in the absence of repair of that single strand break, the DNA replication fork moves forward and you end up with a double strand break. And normal cells have a separate and alternate pathway of homologous recombination, which repairs those double strand breaks. And the HR-mediated DNA repair will allow that cell to survive. However, what you can see on the right in the green is that cells that have a deficiency or an aberrancy in homologous recombination will actually not be able to repair that double strand break. BRCA is one of the critical components of homologous recombination, and in the absence of functional BRCA, or what we call BRCA deficient, the cells cannot repair that double strand DNA damage, and the cells will die. And this concept of a normal cell with intact homologous recombination being able to repair double strand break, and an abnormal cell, such as a tumor cell with a BRCA deficiency, not being able to repair that is what's called synthetic lethality. And it really is a exploitation of the differences between tumor cells and normal cells. Now, what you can see in the center panel is that there is more than one process for repairing DNA double-strand breaks. What we have outlined there is the homologous recombination pathway, and that is what can be critically deficient in approximately 50% of ovarian cancers. There are other processes for repairing DNA double strands, such as non-homologous end joining or NHEJ. What you can see over on the left is that the single strand break, which is critically dependent on PARP for base excision repair. And what you can see on the right is other mechanisms for DNA damage repair, in particular through the nucleotide excision repair and synthesis and translesion synthesis, and then mismatch repair over on the right. So there's multiple processes, but the critical link here is that the single strand breaks that are not repaired in the presence of PARP inhibition proceed to double strand breaks, which require homologous recombination. So why is polyadp ribose polymerase an excellent therapeutic target? Well, we've talked about in the center these two mechanisms for repairing double-strand DNA break. On the left is the homologous recombination, which when it functions gives high-fidelity DNA repair and cell survival. The non-homologous end joining on the right is actually quite error prone and is not a very efficient way of repairing DNA double-strand break. And so inhibition of PARP really, in the presence of homologous recombination, pushes toward that non-homologous end joining repair mechanism. So cells that are deficient in homologous recombination really do not have a great process for fidelity of an error-prone DNA repair. So again, as we've seen here, the PARP inhibitor in the setting of single-strand break does not allow for repair of that single-strand break, with the replication for moving ahead and causing DNA double-strand breaks. In the normal cells, you get repair of this with the homologous recombination repair pathway and cell survival. And on the left, the homologous recombination repair deficient cancer cells will not be able to repair that, again, leading to synthetic lethality. Now, one of the important factors is that in patients who have inherited a germline BRCA mutation, they have one cell with intact BRCA and one cell that has a mutated BRCA. And what you can see in the curve on the right is a survival curve with logarithmic increases in PARP inhibitor concentration. And what you can see in the gray curve is a cell that has intact BRCA2 function. But in the dark blue triangles, what you can see is a cell that has one mutated BRCA2 and one wild type. So it's a plus minus. And all you need is one normal copy, and the cells will actually be able to repair. What you can see in the orange is the cell that is missing both copies of BRCA2 and that cannot repair its DNA damage in the presence of even low doses of PARP inhibitor. And what you can see here is somewhere between 3 and 4 logs difference when we look at the median survival, which is a huge therapeutic index. And normal cells, even cells that have one copy of the BRCA gene mutated, can have intact homologous recombination in the presence of PARP inhibitor. But cells that are missing both copies are exquisitely sensitive. And what you can see on the left is even in someone who has inherited a BRCA mutation, their normal cells will have one normal copy and one abnormal copy. But on the bottom, the tumor cells will have lost the second copy and will be exquisitely sensitive to the PARP inhibitor with the inability to repair the DNA damage. Now, what fraction of cells do we, of ovarian cancers, do we consider to be susceptible to this? And what you can see here is data from the Cancer Genome Atlas and from other sources that show that about half of high-grade advanced ovarian cancers will actually have some aberrancy in the homologous recombination pathway. What you can see in the upper right in the green are BRCA1 and 2 germline mutations, BRCA1 and 2 somatic mutations, BRCA promoter methylation aberrancies in the green, which lead to abnormal BRCA function. And then in the blue, mutations in the tumor in different homologous recombination pathway genes, including the RAD51 genes, other homologous recombination DNA damaged gene mutations. And that whole group is considered the HR deficient, as you can see in the little red note on the right. Down at the bottom, the two orange are possibly HR deficient. This includes PTEN mutations and MC amplification. And then on the left, HR proficient, which are cells that may have other aberrancies, such as cyclin E1 amplification, mismatch repair mutations, or others, but will not be considered susceptible to PARP inhibitors. And so again, about 50% of these of high-grade serous epithelial ovarian cancer will have some defect in homologous recombination. It's really critical to have this information available by the time a patient completes their initial therapy, and that can and should include germline testing and tumor testing. So this is sort of looking at a kind of a variation on the Venn diagram. BRCA1 and 2 mutations are the most important aspect of homologous recombination deficiency down at the bottom. They also can have tumor somatic alterations in BRCA1 and 2 that essentially function the same way and inhibit homologous recombination repair. And then in the lighter blue, what you can see is what some people have called HRDness, where there can be either changes in a normally produced protein, but aberrancies in post-translational modification of these to make them non-functional, or select non-DNA damage repair genes, such as ARID1A, particularly in ovarian clear cell cancers, changes in metabolism or tissue oxygenation that might affect this and lead to loss of efficiency of the homologous recombination repair pathway. And then in the white, what some people have referred to as Parpness, which is variants in genes, RNA or protein expression aberrations. And the further out we get, the less clear it is how much this impacts the homologous recombination pathway and the efficiency of PARP inhibitor therapy. So the ASCO guidelines from 2020 for genetic testing in epithelial ovarian cancer very clearly state germline testing should be done for BRCA1 and BRCA2 and other ovarian cancer susceptibility genes, and that this is recommended for all patients with epithelial ovarian cancer, and we include in that patients with primary peritoneal or fallopian tube cancer, regardless of their clinical features or their family history. And this is usually done with a large gene panel that will look not just at BRCA1 and 2, but other cancer-associated genes. We also, on the right, recommend somatic tumor testing for both BRCA1 and 2 pathogenic or likely pathogenic variants for patients without a germline pathogenic variant, and that testing for these is recommended at the time of disease diagnosis or as soon as possible, with the goal of having these results before the patient has completed their initial therapy, so that you can make decisions about the benefits and the recommendations for PARP inhibitor maintenance. So how do we look for homologous recombination deficiency in the tumors? There's actually several ways of doing this. We actually look for the expression of the BRCA genes and other homologous recombination repair genes down on the right, such as the RAD51 genes, BRIP1, ATM, the Czech genes, CDK12. But there are also other assays that can be done. And one of these is the MyChoice assay, which actually looks at genome-wide loss of heterozygosity, or LOH, telomeric allelic imbalance, and large-scale state transitions, and actually combines the data from those assays into a homologous recombination score. And based on studies that have been done in ovarian cancer, 42 is considered the cutoff. An HR deficient tumor will have this genome instability score of 42 or greater, or have a BRCA mutation that's identified in the tumor. And HR proficient tumors have this genome instability score that's less than 42. It should be pointed out that when this type of testing is done, there will be a significant percentage of tumors for which it's unable to be determined. All of these assays cannot be done reliably. And so there will be a number of patients who have these assays where they get a score that cannot be determined. On the right, what you can see is sort of probably a simpler assay, which is the loss of heterozygosity score from Foundation 1. This has been used particularly in recurrent ovarian cancer trials, the Ariel 3 trial, to look at a measure of homologous recombination deficiency. Again, you saw that that's one of the three parts of the MyChoice score, genome instability score as well. So these are at least two. There are others that are coming down the pike and others that are being used as well. These are the two that have been used in clinical trials that have resulted in FDA approvals of PARP inhibitors. So speaking of FDA approvals of PARP inhibitors for ovarian cancer, what we can see in this timeline is the first FDA approval was in 2014 with olaparib, which was approved for germline BRCA mutated recurrent ovarian cancer. 2 years later, in 2016, rucaparib was approved for germline or somatic BRCA mutated recurrent ovarian cancer. And then what you can see in the double ones are the maintenance approvals for platinum-sensitive ovarian cancer, olaparib in 2017 for maintenance, niraparib in 2017 for maintenance after treatment of platinum-sensitive ovarian cancer, rucaparib for maintenance in 2018, and then the first approval for first-line maintenance was olaparib for germline or somatic BRCA mutated ovarian cancer in 2018. Niraparib in 2019 was approved for patients who have homologous recombination deficient recurrent ovarian cancer. And then what you can see, the 2020 approvals of niraparib as first-line maintenance in platinum-sensitive ovarian cancer, and the combination of olaparib and bevacizumab for homologous recombination deficient positive patients in first-line maintenance. This is basically a little more detailed summary of those approvals. You can see in the first line the mechanism of action for both olaparib and rucaparib is inhibition of PARP 1, 2, and 3. Niraparib inhibits PARP 1 and 2, but maybe actually a more potent PARP inhibitor. And then again, the treatment indications for primary therapy, for maintenance, and then the recommended dosage. For niraparib, keep in mind that that the different doses are used based on the platelet count and the patient's weight, and this is based on data that Dr. O'Malley will be talking about in a little bit more detail. And then you can see the approval dates in the bottom line. So there's clear toxicities associated with these agents. There are hematologic toxicities that affect all three cell lines: anemia, thrombocytopenia, and neutropenia. There are non-hematologic toxicities, GI toxicities of nausea and vomiting, asthenia and fatigue, diarrhea and constipation, and then rare ones of acute myelogenous leukemia or myelodysplastic syndrome, referred to as secondary hematologic malignancies, and pneumonitis. This is looking at common adverse events across the three different PARP inhibitors. What you can see is GI side effects. Anemia is more common in olaparib, but high-grade anemia is not particularly significant. The niraparib is associated with more thrombocytopenia than the other two agents. What you can see down at the bottom, hypertension and dyspnea are associated with niraparib and rucaparib. Increased creatinine and increased transaminases can be seen with rucaparib. And these are all toxicities to look out for, but most of these will not limit your ability to treat the patient. What you can see in the center, again, are some of the GI toxicities that will be seen across all of these agents. So the combination of myelodysplastic syndrome and acute myelogenous leukemia, what are called secondary hematologic malignancies, are clearly of concern in this population. Because of the mechanism of action that inhibits the repair of DNA damage, clearly these are going to be events of concern. What you can see here is a summary of the data in ovarian cancer. On the top, the first-line maintenance studies, and then the platinum-sensitive maintenance studies. And what you can see in the a comparator arm on the right is that the rates basically go from 0 to the highest being 3.1%, but overall quite low rate in the comparator arm, meaning that the basal rate of secondary hematologic malignancies is actually pretty low. What you can see in the PARP inhibitor arm is rates ranging again from less than 1% or 1% up to the highest rate that we've seen, which is in the SOLO2 population. That is all patients with BRCA mutations who are getting a PARP inhibitor as maintenance after second-line platinum-based chemotherapy. So these are patients who have had one full course of platinum-based therapy. They've had to have recurred more than 6 months after completion of that, and are now getting treatment at the end of a second-line or greater platinum-based therapy. So these are patients who've been through 2 complete courses of platinum-based chemotherapy and then get a PARP inhibitor. And in that group, there's an 8% incidence of secondary hematologic malignancies. From the NOVA trial, similar population that included both BRCA mutation carriers and non-BRCA mutation carriers. In the most recent update in the patients with germline BRCA mutations, the incidence of secondary hematologic malignancies was 6.6%. So it's concerning that potentially our BRCA mutation carriers who may get the greatest benefit from this may also be at increased risk for these secondary hematologic malignancies. And we're keeping our eye out on these all the time. There's a lot of information on the internet about ovarian cancer, and patients benefit from using the most reputable sources. Patient advocacy groups such as the National Ovarian Cancer Coalition provide an invaluable support to those with ovarian cancer and their caregivers. NOCC has a number of resources available to aid patients at any stage of their ovarian cancer journey, including expert videos, peer-to-peer support communities, and other educational programs. You can direct your patients to organizations such as NOCC to access resources designed to help them engage in their own care and empower them to participate in shared decision-making. So I want to finish up my part here with a case. This is a 66-year-old woman who had stage 3A2 high-grade serous ovarian cancer. She was completely grossly resected, so optimally debulked, in January of 2018. She underwent germline genetic testing that was negative, including BRCA1 and 2. She was treated on a clinical trial with weekly paclitaxel, carboplatin, and an immune checkpoint inhibitor, avelumab, for 6 cycles from January to June of 2018, and then had avelumab maintenance. But the treatment was discontinued in January of 2019 after she'd been on maintenance for about avelumab maintenance for about 6 months, because findings of the Data Safety Monitoring Board showing that there would be no difference in outcome with the investigational treatment. We decided at that point in time, because the data from SOLO-1 had come out, to do tumor testing, and Foundation Medicine identified a somatic BRCA2 mutation noted here. So what treatment options would be available for her? So think about her as we go through the data, and we'll talk about the course that we took with her in a little bit. I'd now like to turn this over to my colleague, Dr. David O'Malley, who's director of GYN Oncology at The Ohio State University. And he's going to summarize the data for us on PARP inhibitors in management in the first-line setting. David?
Thanks, Deb. Gosh, so honored to be here with my friends, Dr. West and Dr. Armstrong, some of the smartest people I know, and what a great background introduction. An interesting case to start with. This is the uniqueness of having new information shortly after finishing primary therapy, but also the somatic mutation and the importance of tissue testing here. Well, I can't go forward without really recognizing the great work on the National Ovarian Cancer Coalition. Really an impactful advocacy group, particularly for those patients who are newly diagnosed, offering peer-to-peer support groups, both in person and online, as well as educational support and care kits for newly diagnosed patients. Take a moment and make sure your patients are aware of these resources. You can reach them at nocc@ovarian.org or 888-OVARIAN for a telephone. Ovarian.org is their website. Look at those resources. Make sure your patients, hopefully not your parents, your patients are aware. Now, we're going to go over the 3 trials which are impactful. The 4th trial, Vilia, which also is a New England Journal of Medicine article, will not be discussed as that age is not going forward. So SOLO-1, looking at BRCA-only patients, olaparib versus placebo. PRIMA, using niraparib versus placebo in all comers. And PAOLA-1, olaparib and Bev versus placebo and Bev. And again, all-comer population. We'll talk about the sub-analyses and more about each one of these trials. So let's start with SOLO-1. This is all comers, stage 3 or 4, but they had to have had a germline or somatic. Now, a very small number of patients with somatic actually enrolled on this trial. They needed to have been responding to, or responded to, I should say, platinum-based doublet. And then they were randomized in 2-to-1 fashion, placebo control, olaparib 300 milligrams twice daily versus placebo. They're treated for till progression, toxicity, or completing 2 years of therapy. For those patients who were at a PR at 2 years, they did have the possibility of continuing therapy. Now, the primary endpoint was investigator-assessed progression-free survival with multiple other secondary endpoints. This is the trial that changed the world. Literally changed how we think about and treat ovarian cancer. We've never seen curves really almost in any solid tumor looking at these outcomes. The original report by Dr. Katie Moore, a good friend to all of us, showed that at 3 years, 60% of patients on the olaparib arm still had not recurred, versus 27 patients on the placebo arm. Obviously, the median progression-free survival at the original report was not reached. This led to the approval for olaparib in this setting in 2018. This past year, Dr. Moore presented the updated survival. And you see that the progression-free survival continued to show benefit well beyond the 2 years of treatment. And you see the curves in the olaparib arm really not change after we stopped therapy like we did with Bev in GOG 218. And now we can assign a median progression-free survival of 56 months. 56 months. Are we now curing half of our patients with advanced ovarian cancer if they have a BRCA mutation? They haven't recurred at 5 years. Compared to 21%. I was one of the people out there saying, you know what? We're curing much more of these BRCA patients than we think. You know what? We probably cure, and I'm not sure maintenance even really makes a difference. Guess what? I was wrong. When you look at the number of patients cured with advanced ovarian cancer and BRCA mutation using a platinum doublet treated in this usual fashion, unbelievably consistent, 15% plus or minus 5%, and it doesn't matter if they have a BRCA mutation, maybe up to 20% across all of our trials. This is, at this point, a BRCA mutation testing is absolutely necessary to have patients who are BRCA positive to get a Parp inhibitor in the upfront maintenance setting with advanced ovarian cancer. But it doesn't come without toxicities. And it's very important that we educate our patients on these toxicities, those most common being nausea, fatigue, and even vomiting. Approximately 1/3 of patients needed to be dose reduced. And actually, that's pretty good when we're looking at Parp inhibitor trials in this in Solo 1. Usually, it's about 2/3 of patients. Again, very motivated population here. Mostly we're all germline BRCA patients. That may have kept patients on treatment more often, but I think we see a well-tolerated regimen. Grade 3 toxicities are greater 40% in the olaparib arm. Dose interruptions, 52%. Dose reductions, about 1/3, 29%. We already talked about the MDS-AML, about 1%. Also an important consideration. When are we going to decrease our risk of MDL? Looks to be if we treat them in the upfront setting and we stop therapy at 2 years. In the update, we did not see that change. It was up to about 1.5 in the most recent update last year. Now, PRIMA. PRIMA was the second trial, but the first in an all-comer population that is reported here. This was a higher risk population of patients. They had to have gross residual disease at the end of the primary surgery, or they had to have been neoadjuvant or stage 4. So when we look at and compare median progression-free survivals with PRIMA versus other trials, we have to be careful because there's a higher risk population. They had to have responded to their primary therapy. And then they randomized 2-to-1. Niraparib, the first 2/3 of the patients at 300 milligrams, or the personalized dosing for the last 1/3 with using personalized dosing versus placebo. Once again, primary endpoint progression-free survival, in this case, BICR, non-investigator initiated, and key secondary endpoints. Now you see here on the left, this is the HRD population to include BRCA patients. We see an improvement of 57%, so a hazard ratio of 0.43, with a doubling of the median progression-free survival, 22 versus 10 months. And we look at the entire population of patients, we see that the benefit persists, though more modestly, at a hazard ratio of 0.62. And we look at that HR proficient group, I should say. Liz Swisher would have my head if I said HRD negative. What we continue to see persistence. Median progression-free survivals in the intent to treat population, the delta there is about 5.5 months. So again, seeing benefit across all patients. Now, I alluded to, and you heard Dr. Armstrong allude to, the individual starting dose, what I call a personalized starting dose. The individual starting dose is in those patients who are less than 77 kilos or their starting platelets are less than 150 milligrams. And as I said, about 2/3 of the population in PRIMA did not use this criteria, meaning they were started at 300 milligrams. After an amendment in the protocol, about 1/3 of the patients, we did use the individualized starting dose. And on this slide, you can see the impact on grade 3 or more thrombocytopenia, reducing it by about 48% down to 21%. Anemia from 35 to 22, and neutropenia also was reduced. Modest impact or minimal impact on hypertension. Now, we do see the hazard ratios are not statistically different between those two. But it is 0.59 versus 0.69, so something to consider. Very important when selecting for your dosing to consider the weights and plates. 77 kilos or platelets of 150,000. Polyp reported around the same time, actually the exact same time, also New England Journal of Medicine article based from Europe and our NGOT colleagues. Again, advanced stage patients, first line, needed to have platinum-based therapy to include Bev, and Bev had to be included for at least 3 cycles in their primary therapy. Patients were stratified by tumor BRCA mutation and the first-line treatment outcome. 2-to-1 randomization. Now, what's important about this trial? It's the only trial with an active comparator arm in the maintenance setting, in this case Bev, at standard 50 milligrams every 3 weeks. It was also placebo-controlled. Olaparib, standard dose, 300 milligrams twice a day. Primary endpoint, investigator assess PFS. Okay. And we look at the subpopulations from left to right. HRD, including BRCA, with marked improvement. Hazard ratio is 0.33, 67% reduction in this. When we look at the HRD population excluding BRCA, we see that impact persist. Now remember, this is against the active arm of Bev. This is not placebo. And we're looking at the differences in our median progression-free survival in this non-BRCA HRD population. It's a year longer in the median progression-free survivals. Now, in this subgroup analysis, they also looked at the HRP population, or unknown, and there was no statistical difference between these arms, and really just a very modest numeric difference. The FDA, because of this group of patients not showing benefit like it did in PRIMA, did not approve for an HR population, homologous recombination proficient group, I should say, but did approve it, the combination of olaparib and Bev, for HRD patients to include BRCA. How about the cost of the second agent in our toxicity? Well, actually it was just with each one of those individual agents, and we didn't really see additive. Actually, interestingly, we saw protective on hypertension. And I'm yet to hear a clear explanation why this happened. Anemia, lymphopenia, fatigue, very consistent. Again, these are grade 3 listed here. We did see dose interruptions about half the patients. Dose reductions about 40%. So again, pretty consistent with our other patient populations. And the discontinuation rate was a little bit higher than expected at 20%. in this group of combined olaparib and bev. Now this is just a sub-analysis, unplanned sub-analysis, just presented this year at ASCO. And this is in follow-up to some data we saw at ESMO this past year, which is looking at these subpopulations of patients to see if they benefit more or less. In this report, we have stage 3 and stage 4. Now, interestingly, the impact from a hazard ratio standpoint was exactly the same. Hazard ratio is 0.32. But your median progression-free survivals were 20 months longer in the stage 3, 20 months difference in the stage 3, and approximately 12 to 13 months in stage 4. So this low-risk group, I think we may need to start rethinking that, because now look at 2 years of the stage 3 patients, 72% compared to mid-30s in stage 3 patients with the combination. And at 36 months, you see that persistence continuing. Could we potentially be impacting, really markedly impacting 70% of our HR deficient patients with a combination of these agents? I think we need to look at that. So though compared to stage 3 and 4, the hazard ratio are exactly the same, the numeric difference in the progression-free survivals markedly favors the lower risk patients. So what do we have and what are our choices? Let's look at BRCA-associated disease to begin with. We have olaparib or niraparib. Olaparib can be used with or without bev. So what we would consider is switch maintenance. I don't love that term, but what do I mean by switch maintenance? Stop the treatment you're on, switch to something else. Okay, that's what I mean by switch maintenance. Now, if they're already on bev, you have the additional maintenance of olaparib in that scenario. How about in the HR deficient patients? Olaparib plus bev or niraparib with switch maintenance. How about the proficient patients, that biomarker negative group? More challenging. If you're on bev, you continue it. But should we be considering niraparib? We saw the benefit in that patient population. Is it reasonable to go with no maintenance and watch these patients? It's within the NCCN guidelines, and you see it listed here. I would argue when we're talking about advanced stage ovarian cancers, do we really have a low-risk group? They 80% to 85% recur. Is it time to start asking, should we be giving maintenance therapy, but which maintenance therapy should we give? I think it's a fair question. And when should we use some of these therapies? For example, if a BRCA patient, well, why don't we just wait? Well, for one, you might miss the opportunity for cure. 2, your impact, as you see here, rather than an improvement in 13 to 14 months, is an improvement for more than 3 years in progression-free survival. And you potentially have a 50-50 chance of potentially curing the patient. We need more data on that. So one of the things I consider when the patient's sitting in front of me, it's a little bit different when I'm on the podium, but not much. I sit there and look at stage. Are they stage 4, stage 3? I told you I'm starting to dismiss that because I'm not sure. All these unplanned sub-analysis, we probably put way too much weight in them. How much disease did they have at their primary surgery? I don't really look at the interval. Maybe I do. I guess if I leave disease behind on the interval, I'm more apt to definitely do maintenance because those patients are not going to do well. How about the response to chemotherapy? If they have a partial response, well, I'm definitely doing maintenance therapy. Okay? You could argue, you maybe give a little bit extra cytotoxic, but don't quote me on that. How about the patient choice? Sit down and talk, have a shared decision. That's really what it comes down to. That's what we're talking about, right? A shared decision. Our National Ovarian Cancer Alliance discusses that. talking about toxicity profile, talking about the schedule, talking about oral therapy is chemotherapy every day. That is impactful. And what should we do at relapse? Should we wait for it? Well, I don't think we should. But clearly, germline and somatic testing needs to come into this discussion to make a well-informed decision. Thank you very much.
Thanks so much, David. Really compelling. And we'll talk about these data in just a minute, but I wanted to finish up with the patient that we had presented. As you saw from the dates, she was on maintenance immune checkpoint inhibitor for about 6 to 7 months. And during that time, the SOLO-1 data came out and was published. And so as she came off of study, we checked and she had a somatic BRCA mutation, we knew she did not have a germline BRCA mutation. And she and I had a long discussion. You know, the data was from a trial where people started the PARP inhibitor maintenance, you know, within a few weeks of completing chemotherapy. So she didn't really meet that criteria, but she had a somatic BRCA mutation, and we really felt it was worthwhile. So she started olaparib in February of 2009 based on the SOLO-1 data, and completed her 2 years of olaparib this February and remains in remission. So a little bit of a different scenario than the clinical trials, but the kinds of things, you know, we have to address as data come out while we're treating our patients. We have some questions coming in from the audience, and maybe we should step back and talk a little bit about this. Shannon, maybe let's start with you. What testing should be performed first, germline or tumor testing? Tell us a little bit about your approach in terms of what you do when you do it.
Absolutely. Well, I think the bottom line is you're eventually going to need both, but you can use a lot of different strategies. There are some testing companies that will do everything at once for you. At MD Anderson, what we do is we start with germline. And there's a couple of reasons for that. If you find a germline mutation, then you don't really need to go on with any further testing at that point. You know what you got and you know what you have to do. And if you check somatic first, you run the risk of missing about 5% or so of those patients that have a germline mutation. So that's kind of the highest bang for your buck start. And then what we'll do is we'll trigger, if we do not find a germline mutation in BRCA, then we move on to check somatic as well as HRD. So we do both kind of at the same time. And there's a couple of reasons for that. I mean, I think, you know, Dr. O'Malley did a great job of really showing all of the data and showing that you do have an opportunity to use PARP inhibitors in all comers. But just like we've seen in second line, spoiler alert for my part of the talk, you know, it is a stepwise improvement or reduction really in the benefit that you get based on whether or not there's a biomarker, where you get your best benefit in those patients that either have germline or somatic BRCA mutation, a little bit less benefit, but still good in those patients that have homologous recombination deficiency, and then the least benefit, but still something in those patients that have homologous recombination proficient tumors. So I like to have all that information so that when I'm performing that counseling and really getting into the shared medical decision making that Dr. O'Malley was talking about, we really have all of the information in front of us, you know, so we can make a good decision.
Right. David, what about you? What's your approach?
Well, you know, similar to Shannon, but I would disagree a little bit on starting with the somatic. And the reason that I don't like to start just with the somatic is when the patient's sitting in front of me, I want to be able to tell her, do you have a germline mutation? So many of my patients, the first thing they think about is, did I give this to my kids? I want to be able to tell them that. So what we do is we try to do as much as we can, do both somatic and germline at the same time. And I start with an HRD test. First, we just recently, after Journal Club, we got our whole group together, came up with a consensus. So we send them to Myriad My Choice, getting that HRD score. Upon recurrence, we will then perform more extensive next generation sequencing for the entire molecular testing, looking for those actionable mutations, looking at some of these really neat opportunities we have for targeting therapies, antibody-drug conjugates at time. That's our current approach, and I really look forward to a day where we can have the reliable HRD test and the next generation sequencing. Not to say some of the commercials out there are not reliable. I just don't have as quite as much confidence in that testing beyond the myriad my choice.
Well, and the audience is going to be lucky to hear that, we have 3 different approaches, because we do germline testing and everybody try to do it right at the beginning. And we also send tumor testing off for looking for somatic mutations as well. And then make a decision down the line about whether or not we want to think about niraparib maintenance in people who are negative, whether or not they have HRD or not. And usually it's a discussion with the patients whether or not we're going to do HRD. And I'm going to say we have some variation in our group at Hopkins. Some of our practitioners send HRD off on everybody. Some of us only send it off in some, because we're leaning toward giving the PARP inhibitor based on PRIMA, giving the PARP inhibitor almost no matter what. It certainly does give you information about the benefit. One of the interesting things when you look really teased down in PRIMA is that when you look at obviously everybody's interested in what's the difference between the control arm and the PARP inhibitor arm, but these characterize these as different risk tumors. So the arm of patients in PRIMA who had a BRCA mutation and didn't get a PARP inhibitor, had a median progression. Again, it was, as you said, poor risk population, median progression-free survival of 10.9 months. Patients who were BRCA wild type but had a homologous recombination deficiency had a median progression-free survival without a PARP inhibitor of 8.2 months. And the patients who had no germline or somatic BRCA mutation and were HR proficient had a median progression-free survival of 5 to 6 months. So it's actually giving you some characterizations of the tumor, sort of certainly about the PARP inhibitor potential benefits, but the patients who are HR proficient and do not have a germline or somatic BRCA mutation, there are bad actors, and so even though, you only get about 3 months additional benefit in progression-free survival, in the tail of the curve, when you look out from PRIMA at those patients at 22 to 24 months, the control arm, just chemo, 90% of them have relapsed, and it's closer to about 75 to 80% in the patients who get the PARP inhibitor. So your chances of not having relapsed, are significantly improved. It's one of those where the tail of the curve maybe gives you a little more information than the median PFS.
Yeah, Deb, it's interesting. I think there's so much there that you just said. For me, if you're going to give PARP to everybody, still getting that germline testing, obviously, we talked about, so important, right? So even if you're not going to utilize the data, at least get the germline. Now, with regards to the tails, it's really interesting because we all have those patients in our practice that are HR proficient that have gotten this amazing response to PARP inhibitor. Probably something to do with the heterogeneity of the tumor, as well as the testing is just not at the level it should be, right? And so we have that group of patients, and when most of those HRP patients will not get access to a PARP in the future because they'll be platinum resistant, that's your one time to get it. And that's what I'm saying, should we be talking maintenance or no maintenance? The question in my mind is which maintenance.
So Shannon, what about the patient that you're gathering your information, you've sent out the germline testing, you've sent out the tumor testing, and you've started them on chemotherapy with bevacizumab. Depending on how the test comes back, what do you do in that situation? Are you going to continue the bevacizumab in somebody who has a BRCA mutation?
Typically I do, because I don't necessarily use bevacizumab in all comers, although I'm also very compelled by the data that you showed, Dr. O'Malley, about that kind of low risk group that seems to benefit so much from the combination. I like to use bevacizumab for those patients that have a lot of ascites or, that bulky disease, and you really feel like you're getting additional benefit, not just from the tumor reduction standpoint, but also just from a symptomatic standpoint. So I will continue that. When we get to the end of chemo, that's when we have a discussion, right? Because for that patient population, you can just add that PARP on. Of course, we don't have data around switch maintenance here, right? That's the missing arm of Paula that we wish we had, to know, could we just stop the bevacizumab at that point? switch over to a PARP, for some patients, that's the right choice. Some patients don't want to be coming in for an infusion. They want to kind of be on their own and go be free. And a pill makes it a lot easier for that. So, certainly that's an option. But then we also kind of review all the data and kind of dig in on, okay, well, this combination, this was the, absolute difference in the months. This was the reduction in the risk of progression. And a lot of patients choose to stay on that combination strategy. And I think it works really well. So I think as long as you have somebody tolerating it, it's a set amount of time. It's not like second line that we're about to talk about where you basically treat until progression. And that can be for a really long time, yielding all sorts of things like the MDS and such that we were talking about. This is a set amount of time, 15 cycles of the bevacizumab, 2 years of the olaparib. If you give somebody kind of that timeline and they can see the end is in sight, I think many patients will choose to stay on both.
And I'll ask both of you, one of the questions I get from a lot of my colleagues in the community who don't treat as much ovarian cancer is, the data from Prima with niraparib is 3 years. The data from Solo 1 and from Pala is 2 years of olaparib. Do you ever go past 2 years of olaparib in somebody who didn't meet the criteria for that? I have some patients who don't want to stop. So.
Yeah, I can go first. I mean, I usually don't, but you're exactly right. There's a population of patients that want to be done, right? It's 2 years. You show them the data. They're like, come on, it goes past those beautiful 5-year curves that happen regardless of patients, stopping at that 2 years. I feel like that's pretty compelling, but we all have those patients that are like, it's like a security blanket. I just want to stay on something, and I think you talk to them about the potential risk of, long-term toxicity with those agents. And if they're open to it, you can keep them on there, but I usually stop at 2 years.
What about you, David?
I was not that long ago. Gosh, I don't want to stop, but what really changed my impression? The MDS on Solo 2. Now, again, there's so many confounding factors there, and we'll really have to drill down at that further. But, that MDS up to 8%, now we're seeing it in Nova at, 6.5%. On those patients, how much is that the platinum? How much is the timing in crossover? I guess in those who are treated, it isn't crossover, but we saw the higher occurrence in the placebo arm than expected too, right? So for me, that was really impactful. And so if they have a partial response with something I think is truly disease, I will have that conversation, encouraging to continue them. If they have a complete response, C125 is normal, we have the conversation, but I've been discouraging beyond 2 to 3 years at this time because of that MDS data from the admittedly recurrent setting.
Well, speaking of the recurrent setting, we're going to move on now, and Shannon Weston from University of Texas, MD Anderson Cancer /Center is going to talk to us a little bit about the data on PARP inhibitors in the recurrent setting. Shannon?
Thanks so much. Yeah, so we're going to take a whirlwind tour through. We've already kind of been hinting at some of these data around PARP inhibitors in the recurrent setting, but first we'll start with a case. This is a patient from my clinic. She was 48. She had a history of stage 3C high-grade serous ovarian cancer, and she did have a somatic BRCA mutation already identified. She had gotten her optimal tumor reductive surgery. She got 6 cycles of paclitaxel and carboplatin intravenously, and was at no evidence of disease at the end of her treatment. Now, she was a patient who was treated Solo 1, pre-Prima, so she didn't get any maintenance. She went on to active surveillance, and approximately a year later presented to me with an elevation in her CA125, asymptomatic. Her CA125 was 574. So we got some imaging. It actually didn't show a ton. Peritoneal fluid in the upper paracolic gutter, some in the lesser sac, gastrohepatic recess, maybe a little bit of tiny little nodules, a little bit unclear. So we ended up getting a PET. The imaging really just showed some fluid, although we did see some lighting up a little bit of the peritoneal linings. So we got a paracentesis and drew out that fluid, and it was positive for adenocarcinoma. So this is a patient, again, we would consider platinum to potentially be an option for her. She does have that somatic BRCA mutation. So let's look at some data to talk about how we might treat that patient and what her options might be. So just like Dr. O'Malley spoke about resources for patients that have just been diagnosed, really survivor groups and advocacy groups can provide such support for your patients across every stage of their survivorship continuum. And so the National Ovarian Cancer Coalition has resources for patients at the time of recurrence, when they're making decisions around best supportive care. They have patient assistance programs like one-on-one counseling and meal delivery. It's a really huge resource, and we really just want to encourage you to get your patients involved. So when we're talking about the use of PARP inhibitors in the recurrent setting, we have two major strategies. The first is utilizing PARP inhibitors in the maintenance setting, so after we've had a benefit from chemotherapy. And then the second is using them in the treatment setting when we have measurable disease. So I'm going to start by reviewing some of the data, and I think many of you are very familiar with these data, looking at the use of PARP inhibitors in maintenance. Now, these studies, which include Study 19, Solo 2, Nova, and Ariel 3 all had a basic backbone. Now there's some differences we're going to tease out as we talk about them, but the basic backbone was the patients had platinum sensitive, high-grade ovarian cancer, at least 2 prior regimens, and their last regimen of chemo was platinum-based, and they had either a partial or a complete response to that and a stable CA-125. These patients were then randomized to either the PARP inhibitor and placebo, and generally this was a 2-to-1 randomization across these trials, and then were treated until disease progression. So this is what's a little different about these trials as compared to the upfront trials. There was not a clear stopping point. Okay. Now, Study 19 and Solo 2 looked at olaparib. Now, Study 19 was in an all-comers population where they did, in fact, tease out BRCA mutant versus non-BRCA mutant, but saw a benefit in an all-comers population around progression-free survival. Solo 2 was with olaparib, but was in only BRCA mutant. Now, we've got these details, a little bit more granular detail around the bottom line. What did we see? And I'm going to cover a couple of things. One, we saw benefit across all the populations, okay? Every population that was explored in these 4 major maintenance trials had a benefit in progression-free survival, had a reduction in the risk of progression when they received that PARP inhibitor maintenance, okay? You can see in that first study, Study 19 of olaparib, the hazard ratio was 0.35 with an overall benefit of about 4 months. Similarly, in Solo 2, now this was an only germline BRCA mutant population, there was a 70% reduction in the risk of progression. Now, I want to tease out Nova, germline mutant 0.27, so what, 82, 78? I'm not good at math, but there was a consistent reduction in the risk of progression across Nova. And then if you look at Ariel 3 BRCA mutant population, a similar risk reduction. So we're seeing very consistent data across those germline mutations. Now, when we span out to look at the non-germline mutations, and that can include patients with homologous recombination deficiency or patients with homologous recombination proficient tumors, you see still there's a nice reduction in the risk of progression, but maybe not as profound as what we see with the BRCA mutant population alone. Now, the only study that has demonstrated an overall survival benefit to date is the Solo 2 study, which again was focused only on those patients with BRCA mutations. And they found that there was a 12.9-month improvement in overall survival for the patient population that got their PARP inhibitor at that second-line maintenance, despite subsequently patients that were on the placebo arm getting a PARP inhibitor therapy. And this again gets at what Dr. O'Malley was talking about how do we sequence these? I think he was very compelling that we should be giving them in the upfront if we can. But if you have a patient in your clinic who has not yet had a PARP inhibitor, who has a BRCA mutation, who has had benefit from chemotherapy, this is the time to use that PARP inhibitor rather than potentially reserving it to a later date. Now, one of the things we were missing from the Study 19 and the Solo 2 study was the idea of what happens for patients that have homologous recombination deficiency and homologous recombination proficiency. So the phase 3 opinion study, which was just presented, looked at olaparib maintenance monotherapy in a group of patients that had no germline mutation, okay, but they teased out the population that either was homologous recombination deficient with somatic BRCA. You can see that's the purple line. The homologous recombination deficient excluding the somatic mutation, which is that light teal line, or completely homologous recombination proficient, which is that yellow line. And again, similar to what we've seen in the other maintenance studies, the biggest bang for your buck was in those patients that had a somatic mutation, followed by those that had the homologous recombination deficient tumors, and then finally the homologous recombination proficient tumors, still getting some benefit from this PARP inhibitor maintenance, but not as much as we're seeing in those biomarker positive groups. Now, this is just an overview of the NOVA study. I want you to remember the NOVA study was a maintenance study that had two separate arms, right? It had an arm for just the germline mutations, just the patients with germline BRCA mutations, and that's in the curve on the left, where you saw this significant reduction in the risk of progression, yielding quite an impressive difference in median progression-free survival. Whereas the other arm included kind of everyone that did not have a germline mutation. And you can see that middle group is the group that had no germline mutation just overall. That included homologous recombination deficient and proficient. So we could see a nice reduction in the risk of progression. But if you tease out that group that did not have a mutation, but had homologous recombination deficient disease on the right, you can see a little bit bigger benefit from that niraparib maintenance as compared to the group of the intention to treat overall. Now, they did look at overall survival in this trial, but remember, it was an all-comers population. It wasn't just a mutant population. And so they saw a trend towards improvement in median survival, but it was not statistically significant. And then finally, the Ariel 3 trial, which looked at rucaparib maintenance. This is the curve that demonstrates that, again, that really profound difference in progression-free survival for those patients with a BRCA mutation who got rucaparib maintenance after the completion of chemotherapy. So now let's transition from that maintenance piece on to the treatment piece. We previously had received an FDA approval for olaparib in the platinum-sensitive BRCA mutant population with either, they had to have at least 2 or 3 lines of prior therapy, and you could treat that patient if they had a germline BRCA mutation. So SOLO3 was meant to be the confirmatory study to ensure that this FDA approval was appropriate. So it was an all relapsed high-grade serous or endometrial cancer patients that had a germline BRCA mutation, appropriate performance status, more than 2 prior lines of platinum-based therapy, and were platinum sensitive. And they were randomized 2-to-1 to either receiving olaparib or a non-platinum chemotherapy. Now, this is my one beef, and I think many of my colleagues would agree with this. A platinum-sensitive population receiving a non-platinum chemotherapy, not exactly the standard of care, but that was the comparator arm that was chosen. And what they found was there was an improvement in objective response in that BRCA mutant population that received olaparib as compared to physician's choice non-platinum chemotherapy. And you can see 9% of patients had a CR, 62.9% of patients with a partial response. And one of the things that really struck me about this trial that I thought was really interesting is, wow, the median time to response was only 2 months. Really impressive to me, because I've always thought that maybe it takes a little longer, and sometimes that you need to give it to patients for a little bit longer to see that benefit. But really, when we see that response, really the median response happens in about 2 months, and the duration of response was about 9 months for those patients. Now, similarly, we have an FDA approval for rucaparib in the treatment space, again, for germline mutant as well as somatic mutant ovarian cancer with 2 or more prior lines of therapy. And so Ariel 4 was the confirmatory trial around this. And this looked at rucaparib versus placebo in patients with a BRCA mutation, either BRCA1 or 2, somatic or germline. And they were randomized 2-to-1 to either rucaparib, and if the patients were platinum sensitive, they could receive a single agent platinum or a doublet platinum chemotherapy. And if they were platinum resistant or only partially platinum sensitive, they received paclitaxel. The primary endpoint was progression-free survival. And what we found is in the entire population of germline or somatic mutated ovarian cancer, that there was a benefit in progression-free survival to the patients that received rucaparib over chemotherapy. Now, interestingly, small numbers, but very, very intriguing. They did look at a group of patients that had developed a BRCA reversion mutation as identified by ctDNA and found, in fact, the opposite. So if there was the presence of a BRCA reversion mutation, there was not benefit. And in fact, there was worse outcomes for patients that received rucaparib in that population. So intriguing that we may be needing to check this in our patients that are in the recurrent setting that may have developed a BRCA reversion mutation. They also looked at, and this was just recently presented at ASCO by Dr. Amit Oza, they teased out the effect of platinum sensitivity, because you'll remember I said they had a platinum sensitive group, they had a platinum resistant group, and then they had this partially platinum sensitive group. And if you look, you saw that there was a benefit for progression-free survival really across all the subgroups, but as expected, those patients with platinum-sensitive disease certainly had a more impactful outcome from the use of rucaparib. And I will note that they looked at safety across all the groups and didn't find any difference. Now, again, similar to what we've talked about before, when olaparib was really being developed, they focused predominantly on BRCA mutants. So the phase 2 LIGHT study teased out not only utilizing olaparib in a treatment setting for patients with BRCA mutation, but also based on homologous recombination deficiency. So this LIGHT study looked at an all-comers population, and these colors will look just like the opinion study I showed you a few minutes ago, where the population that does the best with single agent olaparib in the treatment setting are those patients with either BRCA germline or somatic BRCA mutant, where you can see the progression-free survivals are 11 and 10.8 months respectively, response rates at 69 and 64%. Once you get into that group that does not have mutation but has HR positivity, homologous recombination deficiency, see a little bit less benefit, but still improvement in progression-free survival and a response rate of about 30%. And then that group that's homologous recombination proficient coming in with a 5.4 month PFS and only a 10% response rate. So very consistent data across all the different PARP inhibitors and across all the different populations that we've reviewed. So what about my patient? We talked through these types of data, and she really was hesitant to receive any chemotherapy and decided that she wanted to pursue rucaparib. So we gave her rucaparib as a single agent. She did wonderfully for a very long time. Her adverse events, she had a grade 2 elevated transaminases that really only happened for about a month on therapy and then resolved on their own, and had a little bit of a grade 1 fatigue, but otherwise was able to receive this therapy for 18 months until she ultimately developed progressive disease. And what we can talk about with her going forward is, I think we're going to, over the next kind of conversation, we can talk a little bit about what are her options now and what we can do for her. But first, let's just do a little bit of a recap, just some key points that we want, the three of us wanted you to walk away with when we're talking about the use of PARP inhibitors in ovarian cancer. So really the bottom line, who should get a PARP inhibitor? You should be considering a PARP inhibitor for all patients with newly diagnosed advanced high-grade epithelial ovarian cancer. And that includes patients with germline and somatic BRCA, patients with homologous recombination deficient disease, and then, as I think all three of us have mentioned, those patients that have homologous recombination proficient disease, it really comes down to an honest conversation with them about what their goals are, what the potential benefit of utilizing PARP inhibitors in that space is, and the potential risks that are associated with it. If you have a patient in front of you that's never had a PARP inhibitor but now has recurrent disease, those patients that have PARP inhibitor naive, but irrespective of really their BRCA or HRD status, if they've had a benefit from chemotherapy, or if they have a BRCA mutation in the platinum sensitive setting, you should be considering a PARP inhibitor for those patients. I hope we've convinced you in regards to genetic testing. These patients should have genetic testing at diagnosis, essential to get at the very least germline BRCA1, 2, but also consideration of broad panel testing to identify other homologous recombination genes that might be aberrant. And then consideration of tumor testing as well if the germline testing is negative or not. as my colleagues have said, you can get all of it at once as well. You're going to eventually want to know what's going on with those patients somatically. And then it really comes down to a conversation and really your decision-making of how you use that homologous recombination deficiency testing. We know these patients can have toxicities. It really comes down to making sure they know when they're transitioning, especially off chemo. Many patients are thinking, gosh, I'm just getting a pill. It's going to be great. It's going to be awesome. Management of expectations is key, making them understand that there are toxicities with these medications and that you need to have frequent communication and really be able to help them get through those toxicities with monitoring, watching specifically for bone marrow toxicity with blood tests. And, that can be every month with certain part with olaparib and rucaparib, and then really weekly during that first month with niraparib. Blood pressure is important to monitor, especially with niraparib, which can elevate the blood pressure. And then long-term monitoring for AML and MDS, especially if you've got patients on in the recurrent setting and they're on for the duration until progression. Don't be afraid to interrupt these agents. Don't be afraid to reduce these agents. You can get your patients through, but sometimes you have to find that sweet spot dosing that helps them be able to tolerate it with a minimum of side effects. And really be aware of your supportive measures. Don't be afraid to use antiemetics, anti-motility agents, antihypertensives. Do what you got to do to get patients through these toxicities.
Thanks so much, Shannon. Really great summary. So our final section here is going to be on what's next for PARP inhibitors in ovarian cancer. And so you can imagine PARP inhibitors, because of their benefit in ovarian cancer, are being looked at in combination with just about anything that you might be able to think of. Being looked at with immunotherapy. We've already heard about combinations with anti-angiogenesis inhibitors in the Paula study, with antibody drug conjugates, and with novel DNA damage repair inhibitors. This is a list, not even a complete list, of immunotherapy trials that are looking at combinations of immunotherapy with PARP inhibitor in the frontline setting, in combination with chemotherapy, and sometimes in combination with bevacizumab. So immune checkpoint inhibitor, chemotherapy, bevacizumab, and PARP inhibitor. In platinum-sensitive recurrent disease, looking at combinations with bevacizumab, PARP inhibitors, and immune checkpoint inhibitors, and in the platinum-resistant setting, PARP inhibitors with immune checkpoint inhibitors. PARP inhibitors with anti-angiogenesis agents, there's a number of studies. The OPAL study, which is looking at dostarlimab and niraparib and bev, niraparib and bev, and GY004. So the GY004 study was a randomized phase 3 trial that looked at the combination of olaparib and cediranib versus standard platinum-based chemotherapy versus olaparib alone in patients with platinum-sensitive recurrent ovarian cancer. And you can see the schema here. And patients were randomized 1:1:1 to receive standard platinum-based chemotherapy, single-agent olaparib, or cediranib and olaparib. And what you can see in the table at the bottom, the very bottom line, the overall response rate was 71.3% in the chemotherapy arm, and almost exactly the same 69.4% in the cediranib and olaparib arm, but was inferior to that at 52.4% in the olaparib alone arm. And so while the cediranib and olaparib was not superior to chemotherapy, it was essentially equivalent and gives us the potential option, if and when this combination is approved, of having a non-chemotherapy option to offer to patients in the platinum-sensitive scenario. So a huge issue of interest for us is PARP inhibitor resistance. We know that many patients will develop resistance to PARP inhibitors, and I'm going to turn this over to Dr. Weston, who actually presented this data for this trial last weekend at ASCO, looking at a combination of PARP inhibitor with a WEE1 inhibitor, and to review that and some of the other data looking at PARP inhibitor resistance. Shannon?
So, we know this is a huge area of unmet need where patients are going to develop resistance to PARP inhibitors. As we move those PARP inhibitors earlier and earlier in lines of therapy, more and more patients are going to have that, whether or not they have a germline mutation, somatic mutation, or homologous recombination proficient. And so this has been a real labor of love for me and a real interest of mine. And we've identified a number of different mechanisms of PARP inhibitor resistance. And one of the mechanisms that intrigued us was the activation of the cell cycle, and specifically signaling through a node called WEE1. And what we found is that this is upregulated in those tumors that have PARP resistance. And when you utilize PARP inhibitors and WEE1 inhibitors, you can see synergy and synthetic lethality. So we developed the EFFORT study, which looked at patients that had developed PARP inhibitor resistance and randomized them to either the WEE1 inhibitor adavosertib alone or in combination with a PARP inhibitor. Now, importantly, this included patients that either had platinum-sensitive or platinum-resistant disease. And in fact, the majority of patients on this trial had platinum-resistant disease. And the clinical activity was very intriguing in both arms. You can see here that in the adavosertib alone arm, we had a response rate of 23% and a clinical benefit rate, which was defined as stable disease more than 4 months or objective response. The clinical benefit rate was 63%. And in the group that was treated with the combination of adavosertib and olaparib, we achieved a response rate of 29% and a clinical benefit rate of 89%, again, in a population that had PARP-resistant disease. And so we're very intrigued by these results. Now, there is toxicity of both the WEE1 inhibitor alone and in combination with the PARP inhibitor, but it can be mitigated. We're working on some alternative dosing strategies to see if we might be able to move that forward in a different way. Now, Dr. Fiona Simpkins and colleagues also have explored this area and specifically have focused on other mechanisms of DNA damage repair, specifically ATR inhibition. And so she combined a combination of olaparib with a drug called ceralasertib, which is an ATR inhibitor, and this is the Capri trial. All our trials have such fun names. And this was looking at both efficacy and tolerability of the combination. You can see there were a number of cohorts, but she focused on cohort C, which was in a platinum-sensitive only arm that had had prior progression on a PARP inhibitor. So the numbers are small, 13 patients, and you can see that the majority of these patients had a germline or somatic mutation that were included in this trial. Only a few patients had homologous recombination proficient disease. But wow, look at that waterfall plot. They clearly saw a nice benefit of a 45% response rate in this population that had PARP-resistant disease. And so very intriguing activity, and this is potentially going to move forward for our patients. But, I think that we've focused a lot on combinations. That's certainly been a huge area of interest for me. But we have here an expert, Dr. O'Malley, in antibody drug conjugates, which is kind of like a now for something completely different. But, really, as we're getting this testing and we're trying to work towards precision medicine, really finding abnormalities in our patient's tumor that we can direct high-dose chemotherapy makes a lot of sense.
Well, thank you, Shannon. I think and congratulations on great work and WEE1 inhibitors and what a fantastic moving the bar forward in these exciting agents. But I think as we look at more personalized medicine, let's identify targets that we'll be able to evaluate for our patients. And one really exciting opportunity is the folate receptor alpha. Speaking of labor of love, I started the first in human trial with mirvetuximab now 7 years ago, but really exciting to now be at phase 3 levels. But part of that is a trial called Forward 2, where we had different arms, and we reported this year's ASCO looking at a platinum agnostic group. So patients who are either platinum resistant or sensitive, that would be appropriate for a non-platinum doublet. We're seeing more and more of those patients, somewhat because we're seeing more maintenance, so with that, we're having more platinum-sensitive patients. We're going back to platinum more and more. So platinum hypersensitivities, hematologic toxicities, do these chronic use. So we wanted to get experience in that. And what we found in this population that 60 patients, we had an overall response rate of 50%. And we look at those patients who had high folate receptor alpha, the response rate was 64%. And those high folate receptor alpha patients were platinum resistant, 60% response rate and 70% response rate in platinum sensitive. And almost amazingly so, 32 of the 33 patients who were high folate receptor alpha had decrease in their disease burden based on RECIST. Now, I'd also like to acknowledge some wonderful work by Dr. Flor Backus, who helps lead our clinical trial group here at Ohio State. Because we have to talk about PARP inhibitors, and they're in everything, as Dr. Armstrong said, PARP inhibitor rucaparib plus MIRV. We found out we could combine those MIRV at 5 and rucaparib at 400. Now, when we did that, this small escalation, then expansion cohort, we saw in a heavily pretreated population of patients a 40% response rate with a median progression-free survival of 12 months. Now, what's interesting about this is, again, it's a small expansion cohort, but we now have 2 biomarkers which in the future we'll be able to look at those results, HRD and folate receptor alpha, prognostic and therapeutic. So will there be an opportunity in the future to truly personalize medicine, taking the best treatments and combining them?
And I have to say, the antibody drug conjugates, it's sort of taking our sledgehammer chemotherapy and really targeting it much more to the tumor cells. It's really an exciting avenue of research. So very exciting data. So our key takeaways here: PARP inhibitors need to be considered as options for patients with advanced high-grade ovarian cancer, and really kind of across the spectrum. We talked a lot about first-line, recurrent, and PARP inhibitor naive patients. PARP inhibitor maintenance therapy should be discussed for all patients with newly diagnosed advanced high-grade ovarian cancer, with testing, as we've talked about, to try and help you identify what potential benefit they might get from maintenance PARP inhibitor therapy. BRCA and homologous recombination status are really strong predictors of PARP inhibitor activity, and testing is really important to determine the optimal treatment choice and to quantify the benefit for the patient. PARP resistance can ultimately occur, therefore novel therapies and combination approaches are needed, and discussion and shared decision-making with patients are really critical. So we have some more questions coming in from the audience in the last few minutes that we have. Let's start with what labs do you check prior to starting a PARP inhibitor? David?
We try to keep it simple, depending on what we're starting. CBC. We refuse to stop checking Chem7s. We have to with the creatinine, obviously, but rather just getting creatinine, we still get the Chem7. If it's rucaparib, I get the LFTs. And again, weekly for niraparib for the CBC, and monthly for rucaparib and olaparib.
Great. Shannon?
Yeah, not much different for me there. I agree. Knowing the creatinine is really critical. Making sure you kind of have a baseline of that. I check LFTs for everybody, just to know the patient's baseline there as well. But yeah, really the main kind of key is with the weekly labs for niraparib.
Yeah, I pretty much the same, and as with you, Shannon, we just do the comprehensive metabolic panel that includes the LFTs. But I actually frequently will have my patients come in every week for a nurse visit as well, just to check on how they're doing, make sure that their blood pressure is doing okay. I don't always trust them to be checking their blood pressure at home or be doing it right. So particularly for the niraparib. So we keep a really close eye on them in the first month or two they're on. Once you kind of figured out your dose, making sure the patients tolerate, you can reduce the frequency, but you really don't want to miss low counts for people early on. You talked a little bit about managing side effects, and I think the GI toxicities certainly can be an issue for these patients. And some people don't like to be on antiemetics long term, but frequently people need to do these. The patient that I presented today, she sort of had this sort of low-lying basal queasiness, and really didn't like taking antiemetics, but we found a sort of a regimen of prochlorperazine that worked for her and didn't cause her a lot of problems. So I think you kind of have to individualize it for patients. Have either of you ever changed PARP inhibitors based on toxicity, moving from one to another? Shannon?
I have had a couple of situations where I had one patient that was really struggling with the number of pills and how many times a day. And so we did switch over to niraparib, so she could have the once daily dosing. And then conversely, I've had some patients with just really profound hematologic toxicities on niraparib that, we thought, well, let's try something else, when we just couldn't safely give it even at 100. So I think that, if you have a patient that's willing, it's worth a try. And actually, we were able to successfully give that patient the alternative agent. So, I don't think it's very common, but I think when you're running out of strategies and you really want that patient to get that agent, it makes sense to kind of try every tool in your toolbox.
David, what about you?
I agree. We start seeing these this tolerance over a month or two, and some of it is because we dose reduce and they start to feel better. But there is a certain amount of tolerance, especially from the GI, where if you can get them through those first couple of months, they do better. But again, as Dr. Weston said earlier, really educating. Now, our patients go home with a script for antiemetics, but they don't have to get it filled if they're doing okay. But we want to make sure they have something at home. The other thing that I've started doing recently, and in the past I haven't done probably as much as I should have, is using methylphenidate, trade name is Ritalin here, to help manage some of these side effects. Now, again, it's throwing another pill at a side effect, but we've actually had some really nice luck using the PARP inhibitor-induced fatigue. We've used it for years for chemo-induced fatigue, but now starting to use it some with the PARP inhibitor-induced fatigue.
Another question that comes up is, can another PARP inhibitor be used down the road after someone's progressed on initial maintenance with a PARP inhibitor? And that's actually an issue that is being addressed in the trial that Shannon has looked at, and in the Capri trial that she presented, which we've been participating in. And this is looking at, I have to say, we don't even completely have a good definition of PARP inhibitor resistance. Is it somebody who's on a PARP inhibitor and progresses? Is it somebody who was on maintenance and has been off for a year and progressed? Is that progression? So I think we still have to get a good definition of PARP inhibitor, of progression with the PARP inhibitor. But lots of the studies that we talked about, such as Shannon's study and the Capri study, are trying to look at overcoming this resistance pattern, and particularly in patients with BRCA mutations. So I think right now we're in a little bit of uncharted territory. The issue of secondary hematologic malignancies is going to be very concerning in somebody who got maintenance in the frontline setting and maybe now has a platinum-sensitive recurrence and you're considering it again. That has to be a very careful discussion with the patient. Final thoughts, David?
Well, just responding with regards to going back to a PARP inhibitor when somebody has progressed, and I think you brought up a very important point. We first need to define what is PARP resistance. The patient who stops therapy and then progresses after stopping therapy is much different than the patient who progressed on PARP therapy. I would strongly discourage, if a patient has progressed while on a PARP, to retreat them on PARP outside of a clinical trial. Now, if Dr. Weston, with her WEE1 inhibitor, that makes a ton of sense. Combining WEE1, overcoming that PARP resistance. But outside of a clinical trial, I would strongly discourage it. If somebody has PARP exposure, they stopped because of toxicity or because they've been treated for those 2 or 3 years, I absolutely would go back to a PARP inhibitor in that patient. So, final thoughts: somatic and germline testing, shared decision, partnering with our patients, and moving the bar forward to cure more patients with advanced ovarian cancer through individualized medicine, somatic and germline testing, and really PARP inhibitors in those that are BRCA positive.
Shannon?
Well, David just said like every single possible takeaway there is. No, what I would say is, I think that we're at a point right now in ovarian cancer where we should really be trying to get every single patient access to a PARP inhibitor. But there's still an opportunity to try to select the best place for that. So, like he said, the germline, the somatic BRCA mutant population, that's a no-brainer. We need to give that in the upfront maintenance setting, continue it for those 2 years, and get those patients hopefully cured. For everybody else, again, that shared decision-making, that discussion of what the potential benefits are and how to best give it. And then I would just note that, again, making sure people know it's not just a pill, making sure they understand they may have those side effects, because that patient education and that discussion can really help you successfully get through those first few months, which can be the roughest, and make sure that patient gets the best possible benefit without having to come off for toxicity.
I'd like to thank my colleagues, Drs. O'Malley and Weston, for joining me in this engaging discussion.
Thank you for listening. Download materials and complete the post-test for instant credit at peerreview.com/BDQ860. This activity is supported by educational grants from AstraZeneca, Clovis Oncology Incorporated, GlaxoSmithKline, and Merck & Company Incorporated.